So Dr. Kenneth Donovan is a board-certified internist and palliative care physician with over 20 years of experience treating patients with serious and life-threatening illnesses. He is currently the chairman of medicine and director of palliative care at both Lawrence and Memorial Hospital in New London and Westerly Hospital in Westerly. So the goals of this evening are to define what palliative care is, to discuss which patients might benefit from palliative care, and to differentiate hospice care from palliative care. Um, so without any further ado, I'm going to hand it over to Dr. Donovan, and then we'll take questions at the end when he's ready.
Thank you, Nori.
Thank you for being here.
See if I can cut this out.
So without any further ado, here I am. That may be the only thing they got of you.
Well, thank you, Noreen. Thank you, everybody, for coming tonight. I don't have a ton prepared, so hopefully this will be, a little bit more interactive. But, as Noreen said, I've been in this community for about 20 years now, practicing medicine, and I started out as an internal medicine physician, like a general practice physician. And I started working primarily in hospitals. So you may have heard of hospitalists, which is just a fancy word for doctors who work in the hospital. Some people like us, some people don't. It's been a change in the landscape of how healthcare is delivered. But one thing that I realized while working in the hospital is that, because there were such gaps in care out in the community, that there wasn't a lot of support for people who had serious illness or, potentially life-ending illnesses. And this specialty, palliative care, started to develop, within the last 10 or 15 years. And those of us who work in the hospital and care for really sick patients were kind of poised to get additional training and start doing this. And so, a few of us went on and got board certification in this new field, palliative care, which is kind of linked with hospice care as well. But I want to differentiate that a little bit later so that we kind of don't get the terms confused. But over the past 10 years, in addition to being a hospitalist, I've also been a palliative care physician in the hospital, caring for patients who have really serious illness. And, really, I think of palliative care as just an extra layer of support, and it's really specialized care for people who are living with a serious illness. So, not necessarily a life ending illness. So, it's not just people with terminal cancer, that benefit from a palliative care physician. It's really people who have serious illness that have lots of stress, symptoms, a lot of impact on their quality of life is who I think palliative care physicians really can help. And usually, palliative care is delivered in a team of providers, including nurses, social workers, sometimes nurse practitioners, along with doctors. And really, the goal is specifically trying to improve quality of life for patients and their families. So, what does that really mean? Well, the types of patients that I generally see or that I think benefit from us are people who have serious illnesses like congestive heart failure or COPD, emphysema, or even patients with Alzheimer's disease. They really benefit from having that extra layer of support because, I don't know what your experience has been, but I suspect it's similar to a lot of my patients that, your primary care doctor is very busy, has maybe 15, 20 minutes max to see you in the office, if that, usually running an hour behind. And so, kind of trying to politely rush you out of there because they're trying to catch up. And so you don't really have time necessarily to talk about, how are you doing? How is your pain? How is your anxiety? You're really limited in what you can go over in those visits. And so I think, a good palliative care provider is able to give you that time to actually kind of dive into, how is your illness impacting your quality of life? I see you've been admitted to the hospital 3 times in the last 3 months. What's going on? Why is that? What's happening? Is this related to symptoms that you're having? Is this related to, the medications from one doctor and another doctor all interacting, and there's just nobody really, available to look at this. And so I sometimes tell my patients that, What I can offer them is my time. I'm kind of afforded the time to spend 30, 60, 90 minutes with them. And believe it or not, insurance companies and Medicare will pay me to do that. And so, whereas your primary care doctor may not have that time, I can actually sit. I often don't even say a lot. I just kind of sit and listen for 30 minutes while the patients kind of and their families kind of get off their chest what's been going on. And then, you know, usually have a little bit more time then to help them sort of think through, okay, well, how can we address some of these things? Okay, I can't make your COPD go away. That was 30 years of cigarettes and asbestos and all of that good stuff. And so it is what it is. But how can we deal with the fact that you're in the hospital every 2 weeks, that you're in the ER every week, that you're unable to go up a flight of stairs, that you're limiting the things that you used to do, that type of thing. And so it really allows us to try to relieve suffering, to you know improve quality of life, and really see what we can do to help kind of take some of that burden off you and your families if you're going through a real significant illness. Now I will say we also help patients with cancer and with advanced malignancies as well. So it's not that we're not involved a lot with folks that are going through treatments at Smilo, the cancer center at both L&M and Westerly, but it's not just cancer patients that we're helping. Another big group of patients that I think we've been able to impact are patients who are on dialysis and going through a lot of treatments with their kidneys. And because if any of you have been through that or have family members going through that, you know how much work that is. Just getting to and from dialysis can be a full-time job, and then the amount of energy that it requires to go through those treatments and what it's like after those treatments, can be really stressful for people. And so having a palliative care provider involved can also help you navigate that a little bit. Um, so I think obviously I'm biased because I do this work. It's not what I do full time. Really, I'm mostly a hospitalist, but I do palliative care as well. And so I realize even in my own daily life that there's not enough of us, and there's not enough people who do this work. And sadly, outside of the hospital, and this is kind of the bummer about this talk, is outside of the hospital, there's not really any doctors who do this. We're all kind of in the hospital at this point. And so we're catching you way downstream when maybe we could have made some interventions to keep you out of the hospital and have you enjoy your quality of life. Now, having said that, we still can have a positive impact there. And then we have a team in the hospital that if you happen to see us in the hospital, our team is able to stay in touch with you when you leave the hospital and make phone calls and check on you and make sure that all the things we set in place are actually happening. But I don't really have an office down the street that you could come to if you wanted to see a palliative care doctor. That doesn't really exist right now. I think it will, as this specialty continues to grow. But I think right now, the way that healthcare is structured, we just don't have the right system in place. We don't have really, real teams taking care of patients. I think you guys probably all feel that when you're out in the community. And so a palliative care provider would be embedded in such a team if it existed. That's why it generally works well in a cancer center. So if you are a patient with cancer and you're going to the Smilo Center, there is some palliative care there. It's a nurse practitioner. They don't have a doctor there, but they do have a nurse practitioner a day or two a week that helps to do these things. So it's starting to make its way out of the hospital a little bit. But right now, we're really focused more in the inpatient setting when we're seeing patients. But again, it's the same focus. It's quality of life. It's why are you here? Why are you being admitted to the hospital? Why are you here again? What can we do to keep you at home where you'd much rather be than being here with us in the hospital? And how can we alleviate some of the stress of what you're going through, the symptoms that you're experiencing, etc. I think I'll pause there before I sort of talk about the distinction between palliative care and hospice, just to see if there's any questions at this point. Sure.
So do medical schools, do they provide education for palliative care doctors?
It's growing and it's becoming more common that as one of your rotations as a medical student, you will be exposed to palliative care. It's probably 2 weeks. It's not a big portion. No, no. But I think what you're seeing is, and I think I think this is a mistake that our medical societies made. So 10, 15 years ago, an internal medicine doctor or a family medicine doctor could get board certified in this by proving they've done 1,000 hours of care and taking a test. So you didn't have to go to a formal training program. You could educate yourself, take a test, and then practice. You can't do that anymore. Now you have to do a fellowship after your residency. So medical training is multiple layers of years and years and years, but fellowship is usually the last step. And now you actually have to do a fellowship in palliative care to practice palliative care, which obviously gives you an incredibly well trained provider. However, it gives you a lack of providers because I did it the old fashioned way where I could take a test and just get on the job training. That wouldn't be allowed anymore. So you're going to see less people my age doing this and more younger folks, which is good, but there's not enough of them, quite frankly, because it's not a high paying specialty. And so to go on and do additional years and years and years of training to make less money than people who've done less training than you is not always appealing.
Yet
So
we have more and more and more people dying.
yes,
More and more people
yeah.
in hospitals who need this kind of care
Oh
and
yeah,
their families.
yeah, and it definitely it's nonsensical because if you look at the expenditures for Medicare, depending on the statistic you look at, anywhere from 30 to 40% of Medicare dollars are spent on patients in the last 3 months of their life. And so think about that for a second. A third of our Medicare budget is spent in the last 90 days of people's lives, and it's spent on a combination of things. It's spent on in-hospital care, so people who pass away in the hospital when they really don't want that, but that's just sort of where they ended up. Or it's spent on nursing home care because people are ending up in nursing homes, but they didn't really want to be there. Or it's spent on dialysis and chemotherapy. And so it is challenging. I'm not saying those things shouldn't happen. It's just that often they happen without a lot of thought, or a lot of actual guidance. And so you don't really know any better. And there's just as there's an overworked doctor out in the community, there's probably an overworked ER doctor kind of telling you, yeah, you need to come in and we're gonna do this and we're gonna start dialysis and we're gonna call the cancer doctor and we're gonna, so you need that person who has 60 minutes to sit with you and say, okay, is this what we want? What are our goals here? What are we hoping to accomplish? I, I, I always share a story when people ask me, sort of give me an example of how you've helped someone. I think there's kind of a funny story where I had a patient who was, he was clearly near the end of his life and he was still going to his dialysis sessions and he was so wiped out after dialysis that they couldn't even get him home sometimes. And sometimes they would take him from dialysis to the emergency department because you couldn't wake him up. Everybody thought, it was really rough. And so I sat down with his daughter and his wife, and I said, well, what do you think he would want if he could tell us, like what would he want at this point? Do you think he would want to keep doing this and sort of not even really kind of know what's happening here, or do you think he'd want to be at home? Sitting out on the porch, enjoying whatever time he has left. And, and they said, well, how long is that time? And I said, it's hard to predict. I said, generally when we stop dialysis, if patients really need it, it's 14 to 21 days probably before electrolytes become too out of balance and fluids become too out of balance. That patients usually will slip off into like a coma state, and kind of just drift off. So it's usually 2 or 3 weeks, and but it's hard to predict. And so after a lot of discussions and sort of difficult conversations, the family decided they wanted that. They wanted him to come home and spend the last couple of weeks at home. And 3 months later, the daughter called me and said, "Do you think we made a mistake?" And I said, "Why?" "Well, Dad's still alive." He's reading the New York Times. He's out on the porch right now. And I said, "What do you mean?" He said, "Well, maybe he didn't need dialysis after all because he's still alive 3 months later and Dad is back and we can talk to him." But she said, "But do you think we made a mistake stopping dialysis?" And I started laughing. I said, "What do you mean made a mistake? I mean, he was probably hours away from passing away." And now 90 days later, you're telling me he's reading the newspaper out on the porch. Like I said, cherish every moment. I said, he may not be alive tomorrow, but you got 3 months with him, right? And so I, I share that because there are some studies, particularly in cancer patients, that and pancreatic cancer was the one they really looked at. That patients with pancreatic cancer who have palliative care involvement live 3 to 6 months longer than patients who don't. Um, and when you dig deeper, the reason is a little counterintuitive unless you're in healthcare, and the reason is those patients that live longer were more likely to stop chemotherapy sooner, because those poisons that we're putting into you when there's no chance of curing you usually do more harm than good. So when you have advanced pancreatic cancer, and we know that there is no hope of curing you, the things that we're giving you are pretty rough. And unless you're pretty healthy and pretty hardy underneath that, you're probably going to be in the hospital a lot. You're going to be wiped out. You're going to be, just not enjoying significant quality of life. And the stress of that causes you to die sooner. And it's now been studied and documented in at least 2 studies that it's anywhere from 3 to 6 months that people seem to live longer when a palliative care provider is involved in their care. Um, so, go ahead. Yeah. 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 Not at this point. You should advocate for yourself and request it. Oh, I'm sorry. The question was, for the live stream. Sorry. The question was, if you find yourself in a position of needing a palliative care provider in the hospital, will one just sort of appear, based on a set of criteria? The answer is no, not at this point. Primarily because the resource is so limited, and so having kind of automatic consults is not really where things are at yet. But if you simply say the magic words palliative care, the nurses love palliative care, and so if you say the magic words, we've empowered a nurse to request the consultation. So you don't need your doctor to request it. You don't need anything fancy. A nurse can simply call us and say, "Hey, this patient would like palliative care," and then yes, we'll appear within 24 hours. Yes.
Thank you for being within realizing that this is presently a list of palliative care doctors say in like the
Yeah, so the question is, how would we actually access who practices palliative care and how would we find them? So the reason I gave you this handout is because it links on the top. I was hoping someone would ask this question. So on the top, there's the website where you can go. It's called getpalliativecare.org. And then there's a Find Provider tab. And if you and I actually checked it today to make sure it works. If you type in your zip code, it'll pop up the nearest palliative care providers. That's why I was depressed though when I looked and I realized, yeah, they're all 30, 40 miles away at Smilo in Madison or Smilo in New Haven, or so like I don't even get listed because I don't have an office. So my office is the hospital. So you don't really want to see me.
my next question would be, there's a lot of annexes for hospitals. I don't know what they're called. Affiliated with hospitals.
Yes.
Wouldn't that be an idea to get you out of the hospital?
Yes, actually. So the question is, how could we get us out of the hospital and out into the community? So I've actually been trying to work with some of those facilities to see if we could provide our services there. The first being Smilo and Waterford. We would start in the cancer center, but yes, I think, as you said, there's other places like the Pequot Medical Center. There's the Waterfalls building in Waterford. There's other places where we could be delivering this care. Yeah, it's just I think I think I may be the only board certified palliative care physician on staff at either hospital, sadly. And I think, because of the fellowship requirement now, I think it's just becoming less and less likely. Yeah. And there's such a need in the hospital that we kind of get sucked into the hospital full time. Yeah. Yeah. Good question. um, so yes, but it's we're busy. but I think it's definitely something where it's important, and you get energized a little bit when you help patients. My job is strange. I have a lot of different hats that I wear, and I do a lot of administrative work as well. But I tell my wife that the only days I enjoy are the days I take care of patients. So I think it's although they're long days, I think they're rewarding days. So I think it kind of keeps you going. Well, thank you. I appreciate that. Yes. Yeah. Yeah. The nurses. Correct. Yeah, and why would you, right? Because we don't advertise it. It's not something that's really out in the press. And so, so yes, nurses can advocate for this. They can suggest it to you. Actually, when I told my team that I was coming here tonight, they said, "Oh, just tell them all to say palliative care when they come in the hospital." Yeah, yeah, yeah,
So I still have a disconnect with the need versus the availability.
yeah,
So we're we're living longer,
yeah,
we're living with disease longer. So the need for palliative care is going to get stronger.
yeah,
So I don't understand why the medical community or the schooling can't figure out a way to not have it be so rigorous to fill this need. I mean, we're all living longer. So this is not a problem that's going to go away.
correct. Yeah,
It's just going to actually become more needed.
yeah, yeah. And I think you're right on. I think we do this a lot in healthcare, and I think we approach it incorrectly. So we've instead of expanding palliative care and talking about serious illness and end of life, we've instead made it, we kind of have I think, a fancy term now or a sexy term of chronic disease management. So you may have heard that term. So instead of having more palliative care providers, we have more nephrologists, cardiologists, and gastroenterologists who are managing the chronic diseases, but who don't really, not only do they not really have training in how to improve quality of life, they're uncomfortable with these conversations. I mean, the reason my colleagues call me is because they don't want to talk to you about this stuff, right? It's hard for a doctor who's trained, what, 12, 13 years to save your life to say, hey, we need to have a different discussion today, right? I think we are probably at the point where we can no longer extend your life. So, how are we going to make sure the time you have left has quality and dignity, right? That's not a it's not an easy discussion for somebody whose life is about, you know, saving you, right? And so I think we have changed it to this chronic disease management where, I'm always struck. The first thing I do when I see a new patient is I look at their medication list, and I'm always blown away by the number of medicines that people take, and all of the interactions that those medicines have, and the fact that nobody ever has really sat down and looked at that because the cardiologist is giving you this, the nephrologist is giving you this, your generalist is giving you this, and there's not, believe it or not, with all the millions of dollars we spent on medical records, there's nothing in the EMR that tells us, hey, all of these meds, like, are you sure you want these? Because this patient's 85 years old, and these four medicines cause falls, these three cause dry mouth, these two cause urinary retention, and this one causes confusion. There's really nothing that prompts you to that. And so, if you're a cardiologist whose job is to manage someone's blood pressure, you're happy because the blood pressure is 120 over 80. You're not really thinking about all of these side effects and the fact that that medicine is interacting with the medicine from this doctor. And so even simple things like that we're missing because no one sort of is taking the time or the 10,000-foot view on those types of things. And I'm not completely blaming healthcare. Patients think like this too, right? I mean, you guys are here tonight, so maybe you don't, but the majority of my patients also look at me like I'm crazy when I say, hey, we need to start thinking about another approach here. It feels like giving up. It feels like I'm giving up on them. It feels like they're giving up on their family, feels like they're giving up. Like, our whole society, I think, struggles with this discussion. Um, and there is a magic pill, right? Exactly. Exactly.
And that's
Yeah.
one of the
Yeah.
reasons why we started this group, is
Yeah.
to get people to be more comfortable. You know, we were all born and we're all going to die,
Right.
and our life is in between.
Yeah.
To get to be comfortable about even just saying the word death,
Correct.
or to have you think of your death and what you would like that to look like.
Right.
Um, and when we did our doula training, we were told that what you said, doctors don't like to use the word death. They're in the business of saving lives. And when someone dies, they almost look on it as a failure.
Hmm.
So we have to like shift that paradigm to say that it's a cycle.
Yeah.
And so, you know, as a mother having four children, and you know, you want a good birth for your baby. Well, why wouldn't you want a good death
Right.
as you exit this world? And that's the shift that has to happen. And then on the medication part, you know, I think too often we were listening to the doctors and just kind of saying, okay, we now
Hmm.
you have to advocate for yourself, or bring a family member with you that can say, well, wait a minute, my mom is on this medication.
Yeah.
What will that medication do? You know, it's like we have
Yeah.
to ask the questions to be better advocates for ourselves, and also to have a better death.
Yeah, no, I agree. I think you need to speak up for yourselves. You need to be advocates. Family members need to be advocates. I think it's, it's true. Right. Yeah. Right.
But the child calls the mother, calls you. You don't call the dog.
Right.
Because she knows have no
Right.
or
Well, and that's where I think
they're not wrong.
but that's where I think we're kind of failing as a society, right? Because it's everybody. We're all looking at this the wrong way. We're not looking at it as death is an eventuality, right? Like death comes for all of us, and so yeah, I usually tell people the way I describe it to people is when we've reached the point where cure is no longer possible, the question is what do you I tell them, what do you want your death to look like? Because now you get to decide, right? You get to decide whether your death is in a hospital, at home, in a nursing home. You get to decide what it looks like. Is it going to be and I don't push people in any one direction. If you want to get chemotherapy right up to the last day, that's not my decision to make for you, right? I'll share with you what I think is going to happen if you do that versus if you don't, the good and the bad. But I'll support whatever decision you make, but you need to make an educated decision, and that's what I think we're lacking is we're not making educated decisions. It comes up with sort of transitioning to as you get closer to the end of your life, and I think you guys have talked about end of life wishes a little bit before, right? So, I always tell people like I'm glad that people are a little bit more knowledgeable about living wills and things, but living wills are written by lawyers, not doctors. And when I see one, it really doesn't tell me what to do. It tells me, well, if you, doctor, are basically God and can tell me with 100% certainty that I will not survive this illness, then I don't want all of that fancy stuff. Well, I can never say that. So I use that as just a stepping off point to say, oh, I see you have a living will. Tell me, what does that mean to you? And to a lot of people, it just means, well, I want you to do everything, but I don't want to be a quote vegetable, right? I don't want to be on a machine indefinitely. So that's not a DNR, right? A lot of people interpret that living will is a do not resuscitate. Well, that's not really that. You're telling me you want everything done, but you don't want to linger on machines, right? So these discussions have to get really meaty and into the nitty gritty if you really want to understand what your patients want. And a lot of doctors don't, either don't want to do that or super uncomfortable doing that because you're not trained. I was not comfortable with this either until in my residency, I happened to have an attending physician who was a palliative care doctor. And I went into the room with him and I watched him have this conversation. I was like, oh my gosh, like he just said all of those things to that patient and looked completely comfortable, and the patient actually listened, and that was wonderful. And so I just started copying him. So fake it until you make it, right? I just copied him. I had no idea how to do it, and I copied him, and it went well. And I thought, huh, okay, I'm kind of getting comfortable with this now. Now I get it. I understand now that there's a funny study in medicine that shows that most doctors can only wait 7 or 8 seconds before they speak. And so fighting that urge to sit there and just let you kind of look and think and not have me put the words in your mouth is pretty challenging. But I watched him literally just sit there for about 20, 25, 30 seconds, just nodding politely and waiting for the patient to ponder things. And it's a skill. You have to work on it. And most doctors either have never been exposed to it or are not interested in learning that skill because there's 10,000 other things that we have to do every day, right? So yeah, you have to push. You have to ask, on your behalf to have people around who are going to have these discussions with you, but they're few and far between. Yes, Belinda.
So, no, my question is, when you get old, you don't really want to think about having a lot of aggressive
Hmm.
all that kind of thing. But that's what doctors are trained to do.
Correct.
So my kind of, I guess it's a fear really that one could get caught up in the medical machine.
Yes, you can. Yeah.
And it's hard to escape.
It is.
Unless I can remember your name.
Wait, where's Dr. Donovan? Wait, this doesn't sound right. Yeah.
And I guess you can.
Well, so here's the.
Out of that, but it's
Yeah.
a scary thought because I mean, if you call 911,
Yeah.
then 911 gets into action, and
Correct.
they have to do what they're supposed to do.
They do. Yes.
So how do you stop that? Because I'm perfectly happy.
So for the live stream, in case you didn't hear that, Belinda's bringing up a good point about getting kind of sucked into the medical machine and how do you actually alter the course of that. So I will share with you the dirty little secret that your doctors won't want to tell you, which is when you're not around and we're just talking, we're saying, thank God Belinda chose not to do chemotherapy. Thank God Belinda doesn't want dialysis. It would be so terrible and miserable. Why would she want to go through that? Like when you're not around, we're perfectly comfortable saying to one another, my God, I thank God I was hoping she would say no to that. Right. So we understand that we're kind of pushing it, but we're not doing it. The thing, please don't take away, we're not doing it for financial gain. I hate when that comes up in the media, right? But I'm not saying you're suggesting that, but that's what's often thrown in there. That's not even how we get paid, which is why it's funny. Most people don't even understand how healthcare providers are paid. It's all diagnosis based. And when you see your primary care doctor in the office and you're a Medicare patient, they make like $30 to see you, right? There's no financial gain in kind of pushing you for this. So it's not about money. It's about not understanding how to tell the person who's come to you for help that maybe the help you need isn't a magic pill. Maybe the help you need is just some help processing that this is the end of your life and these are the symptoms. Yeah. And how are we going to exit? What's your exit going to look like? Is it going to be dignified, comfortable, and and surrounded by family, or is it going to be scary in the ER, having people shout at you and all kinds of things? And I think the best gift we give people in the hospital when we do focus when we transition to hospice, because palliative care is not about the end of your life until it is, right? And then when it is, we do transition to more of a hospice mentality where now we're truly just focusing on symptom control. But if we've done this right, it's in a controlled kind of trajectory so that those last few hours, days, weeks are really spent comfortable with your symptoms under control, with your breathing more comfortable, your pain less, your family able to surround you. I love when we have sort of those last 24 hours where the family gets to gather and they're looking through photo albums and the stuff we see. I mean, there's clearly something beyond this because people, when they do, they rally a little bit and they tell me they've spoken to their dead son, their dead, like I mean, if they're hallucinations, they're pretty vivid because they're remembering things. And I mean, it's kind of crazy, the stuff you see at the end of life. You guys have seen this too, right? I mean, it's just there is something that is happening. And so when we can give someone that gift and their family that gift, rather than the phone call from the ER, mom didn't make it, those are tough. I think when you're allowed to sort of grieve and kind of get there, it's a much better death experience, and so you're right. You can easily get sucked in, but it's never too late to stop the line and say, wait, this doesn't feel right. I'm not feeling good. This is too much. I want to reassess where we're at. Let's talk about my prognosis. Let's talk about the symptoms I'm having. I don't care about cycle 6 of chemotherapy. Number 5 almost killed me. So let's take some time and talk about like what's next. And it's hard. I actually get into arguments with the oncologists sometimes because they're the toughest nuts to crack, I think.
I was wondering about that, whether you would
Yeah,
be working.
I work very closely with them. I think they're probably the hardest to actually function with because think about their job, right? Their job is literally to save you from cancer. That's why they exist. So if you went to work every day thinking, okay, most of my patients are going to pass away and I'm going to not help any of them, that'd be a pretty depressing job, right? So I think that they have to come into it with a little bit of a different mindset just to remain mentally healthy. So they really struggle with those transitions. And so I learned early on never to never to treat their patients in a vacuum. So if I'm going to see you and if you're a patient of Dr. Legary over at Westerly Hospital, I'm going to make sure I call Bob before I go in to see you and say, hey, I got a consult on your patient. Tell me where you're at with things. Like, what are you thinking? What's the prognosis? Because if you don't get the other doctors on board, that layer of support just becomes a conflict rather than actual support. Yeah. So I never go in to see you until I've talked to your doctor because I need to understand where they're at, what they've told you, what their expectations are. And sometimes that makes my job more difficult because I may want to get from point A to point B quickly, but if your other doctors aren't there, I've got to go a little bit more slowly because it's not going to benefit you if we're outside of the room shouting at each other, right? So yeah, so we definitely we have to get everybody on the same page, and it's sometimes hard. Yeah.
Linda, I just want to say you don't have to wait until you get sucked into that. You can have conversations with your family members. You can plan now while you're healthy.
Oh, yes, I've done all that.
Yeah, what you want. But I mean, to talk with your family and say, because you may be in a situation where you can't talk for yourself. So then they're going to say, no, my mother's wishes were A, B, C. She did not want this. She didn't,
No, I think we're all,
Yep.
you're right, but I think we're all on the same page. I don't want to he knows where he's going.
yeah, they're not comfortable conversations to have with your family members, but
Did you guys ever talk about MOLST forms or POLST forms here? Yeah. So to me, those are like if you're going to fill out one form for your family, and I don't remember which one Connecticut recognizes. There's a MOLST and a POLST, but I can't remember which is in Connecticut. But they stand for something of life-sustaining treatments. But this is the one that gets into physician orders. Thank you. So this is the one that really spells out like, no, I wouldn't want a feeding tube. No, I don't want a tracheostomy and to be on a ventilator. No, I don't want dialysis. No, like that. And believe me, this helps your family if you do this. I know it's not a fun Thanksgiving dinner conversation, but this is the conversation you need to have at least once with your family because it's incredibly stressful on your family if they have no idea what your wishes are and you can't speak for yourself. And depending on the dynamics in your family, um, I have found that if there's maybe one sibling who maybe doesn't have the greatest relationship with everybody, they sometimes try to make up for it by puffing out their chest and being a little too aggressive with the care they want for mom or dad because they're trying to show how much they love mom or dad. And so it can get really challenging in the hospital if mom and dad have written down somewhere or designated one family member as the decision maker and that person knows their wishes, it just totally diffuses everything else because now we know what Belinda wanted. She told us.
So that's kind of better than like
You know,
living well.
Oh yeah, it's way better. To me, the living wills, I don't want to use the word useless, but they're not very useful documents. Yeah, they are just a starting point. Yeah. Yes. Correct. It's not legally binding. But it's a good document. So we're talking about the pulse
because your
form, right?
family knows.
Yeah. So it's definitely like I can't take that and hold it up and say, "Ha, this is her wishes. This is what I'm gonna do." But exactly. Correct. Now it's you're serious. I like this. Yeah. Now, interestingly, this is one of the few states where it's not legally binding, though. There are some states where it is a legally binding document. I don't know why in Connecticut we're so hesitant to make this actually like like your license where it says organ donor. I'm not sure why, Yeah.
But when you get that form,
Yeah.
they say to put it on a neon colored piece of paper, not a white piece of paper that gets caught up in all the other, like a bright yellow or bright pink, so that it's easily accessible.
Yeah.
Download it on
If you Google MOLST or POLST,
Yeah.
because it's not legally binding, it wouldn't matter to me if you used a MOLST or a POLST. They're both fine. Yeah.
The
Yeah.
MO means medical order, like sustaining treatment, and the P is physician order. That's the only difference.
Yeah, I used to work because I work in Rhode Island too. I think Rhode Island might use MOLST and Connecticut's POLST, but they're the same form. They just have a different acronym. So yeah, I would Google that, get yourself one. It also helps you to have that discussion with your family because it's all the questions that we're going to ask when you come to the hospital. And like I said, it's not legally binding, but if you've written down what you want, like unless your children don't like you, why like why wouldn't they follow it, right? Well, okay, well, mom told us what we wanted, right? Well, I hope a lot of us don't say that because I certainly I'm sure it happens, but I would think that's the minority. I think you've let us off the hook if you've written it down because again, I think when we're in the physician's lounge having coffee, we're happy that you haven't done those things. So I think if you, yeah, it's the first responders. Yeah, that's challenging. So, I think that's harder. And that's where, I think if you do have also a do not resuscitate order, which again, that's a tougher one to discuss. And I think that's probably a whole nother talk. But if you happen to have a do not resuscitate order, it's good to have a little bracelet that says that. We joke that you should have it tattooed on your chest so that when we take off your shirt, we see it. But I think a bracelet probably, works as well. Yeah.
When you talk to the family, do you deal with the kids? Because a lot of times there's a lot of guilt that goes on.
Oh yeah.
Hey, I don't agree with my parent or whatever,
Yes.
and that's not my philosophy. Or she took care of me. I don't want to
Correct.
see her go or whatever. So
Yeah.
that's part of what you do.
I think it's most of what we do and so the question is about families. I think it's less usually the patients usually you know what you want, right? But sometimes it's hard to tell your kids or it's hard to get your kids on board. So I would say the majority of what I do is deal with the family. And I was my undergraduate major was psychology, and so I think it's very comes in very beneficial because I said the same thing. You can see the guilt come out in these conversations, and usually it's usually the one sibling who sort of stands out among the rest, and you can always tell like okay there must have been something with this sibling because they're kind of shutting down, they're not saying anything, they're letting this sibling talk, they're taking over the room, even mom's like looking down now, so yeah, you have to understand that a lot of this is helping people through the stress of what they're going through and helping them to not feel guilty. So I usually do something that is recommended against, but I think it's helpful nonetheless. I usually say what I would do if it were me or my mom. Like maybe when I was 35 I wouldn't do that, but at 52 I feel comfortable enough now to just be a little bit more paternalistic. And so I will say to you, like, would you like to know what I would do? You know? And I'll be honest with you. And I'll say, you don't have to do this, but knowing what I know, this is how I would approach this if this were my mom. And that helps people a lot. We're told not to do that. Like, I don't know why. It makes me human. It makes me sort of like, okay, this is a human being telling me, that this is how they would handle this. So I always say that. I mean, I don't. If it's clear you don't care, because I did have someone say to me one time, "Well, I don't care what you think. This isn't your mom." I was like, "Okay, that's fair." So now I ask permission to share that. I say, would you like to know? Would it help you to know what I would do? Because that often diffuses things a little bit too. If I say, this is tough, and if this were me, I would probably do this, blah blah blah. So, I think that it is more of a conversation than me dictating what we're going to do. And so, yeah, it's always about the family. That's why it's also helpful if you clearly designate who your decision maker is if you can't make decisions. But what you also have to tell your decision maker is, if I'm still of sound mind, it's not your decision. Like, I may have written on a piece of paper that it's you, but I'm still here. So that's if I'm incapacitated, because that's often a fight too. Is mom will decide something, and the daughter will say, "Well, I'm her decision maker, and I override that." I'll say, "But she's fine. Like, there's nothing wrong with her brain." Right, exactly, exactly. But I always go in sort of clinically and I say, but your mom has the capacity to make this decision right now. So you only become her decision maker if she lacks capacity. And so I try to, explain what that means. And because we've definitely had those arguments too, where, and sometimes I'll also say sometimes it's even more difficult because there are financial issues involved, and kids that may be living with parents, and houses that may be going into escrow if not, and so there's often some less than pure motives for why family members struggle with these decisions too. And so that's why I say having it very clearly spelled out, like, even if, because if you don't spell it out, as you may or may not know, it goes to your spouse. So hopefully, if you're married, you'd want your spouse making that decision. If you're not married, if you have just a partner that you've been with for 20, 30 years, it's not them unless you spell it out. It's your oldest child. So there's a clear tree in Connecticut of who makes these decisions if you don't spell it out. And so it's always good to, designate who your healthcare decision maker is, if it's not the obvious person, which is your spouse or your eldest child. Um, yes.
You were going to talk about hospice.
Yeah. So Tertius asked about hospice. So, I think palliative care providers generally also are hospice providers. And so, I like to think of palliative care as kind of a continuum. And so when we're still talking about life sustaining measures and we're not talking about end of life, we're generally focusing on palliative care. But I think when we've reached that transition point where cure is no longer possible, clearly things have sped up, and the end of your life seems to be approaching more quickly, then I think we ramp it up a little bit to, to hospice care. And so that's why I say it's kind of a continuum where it's all a focus on your quality of life. It's all a focus on your dignity. It's all a focus on your pain and suffering. But I think when we make that transition to hospice care, then I think it affords us the luxury of being a little bit more aggressive with those medications and a little bit less concerned about some of the side effects. And so that's when we then start thinking about, we're talking in terms of weeks to months to live rather than years. Typically, the definition for hospice, the way we train our providers, and you've probably all heard this, is, would you be surprised if this person in front of you passed away in the next 6 months? And so if the answer is no, I wouldn't be surprised, then you're a candidate for hospice care at that point. Yeah. And I will share with you that, and you won't see this in your chart, in my chart, because I made sure they hid it because I think it would freak people out. But we started actually asking doctors this question when you come into the hospital. So every one of you, if you get admitted to the hospital now, your doctor is going to be asked that question. Would you be surprised if this patient passed away within the next 6 months? We're doing it to mine some data for the question you asked, which is, should we just be doing automatic palliative care consults on anyone that you say I wouldn't be surprised? Should we just automatically consult palliative care for that patient? So we're calling it the medical surprise question, and it's buried into Epic. But we've hidden it from my chart because I mean, I would think that would kind of freak you out, right? If your doctor, right? Exactly, right. So, uh, no, actually, it's really just.
Could be a lifestyle issue.
It could be, yeah. It's really just when you look at this patient across from you, knowing what you know medically, do you think they're going to be with us 6 months from now? Yeah. So it's interesting to see what the responses are. And this is why I say the conversations we have when you're not around are very different than the conversations we have when you're around, because we're very open and honest with each other. Like, oh my gosh, he's still alive? Like, how is that even possible? Right. And so, I think it'll be telling to see what that data shows. I think that people will be honest because we know patients aren't seeing it. It's really just for data collection. And I think it might prompt us to actually hire more palliative care providers because we're going to realize that we have, I think, an even bigger opportunity than we know. Yeah, we do. Yeah, we do. I actually love that. I usually say to I tell people when I have these discussions and I'm not entirely sure, but I can tell that you're suffering. I can tell that the family's suffering. I can tell that it looks like we're heading in the wrong direction. And everybody is giving me the vibe that, we're ready to start thinking about just quality and rather than quantity. Um, I usually say to people, I could be wrong. And like, I would love it if I become the family joke where like a year from now you say, can you believe Dr. Donovan said I was going to be dead in 6 months? Right? Like I'm okay being that guy because that's great, right? But what I don't want you to do is suffer for the next 6 months. And if we can do anything to alleviate that. And I started to get a little bit more passionate about this when the legislation, I guess I don't know if it was called Right to Die or whatever, something kicked up this year about, and I will tell you as a physician, I don't know many physicians who support that at all. I think that we have failed people in terms of their end of life care if we think that the only alternative is to help them end their life. It means we've probably failed them in treating the symptoms that are leading to the end of their life. And so I think it's a failure of palliative care. It's a failure of hospice. Um, I actually I was excited for a while until I realized I got no funding. But I actually met with Senator Summers and got her to propose a bill um, for a trial of what we call general inpatient hospice in the home. So if you're in the hospital at the end of your life, there's actually a Medicare benefit where we can keep you in the hospital and for up to 14 days and treat you in the hospital with IV drips and all the things we need to keep you comfortable so you don't suffer. We actually got a bill proposed that the DPH is supposed to actually, DPH contacted me to talk about how we're going to actually do it, but we're supposed to trial that level of care in the home. So nurses coming to your home, there's no funding for the bill. So it was passed. Everybody voted yes, and it's now DPH has a year to trial this, and so DPH called me and said, "Well, Dr. Donovan, how are we going to do this?" And I said, "Well, it's great. We're going to have nurses. We're going to have infusion companies. I'll be the doctor." Okay, how are we going to pay them? I said, "Well, with whatever money you were funded to do that." Well, we weren't funded any money to do this, so I don't think that's going to go anywhere. However, I think that we definitely need to do better with symptom control because um, my grandfather was home with hospice and it wasn't a great experience. We only had a nurse once a day. He fell out of bed, he ended up in the ER, his pain wasn't really controlled. I mean, it's how can you really achieve at home with one visit a day from a nurse what you achieve in a hospital with someone at your bedside immediately. So there's a big gap between, end of life hospice care at home and what we can achieve in the hospital right now. And so, it is a little bit challenging sometimes to get those symptoms under control. And so, you know, I, that's why I think we're still so focused in the hospital, because often we end up doing less palliative care and more hospice care because patients aren't having these discussions in the community. They come into the hospital when they're really in crisis, and then we're pivoting quickly to end of life care. And obviously, we don't want people to have any pain or suffering, so we transition to pretty aggressive hospice care in the hospital. And then we usually work with the hospice agencies in the hospital.
Ever get a patient that resists palliative care because they feel accepting it in their head that they would die sooner?
All the time. Yeah. So a lot of patients reject palliative care, mainly because they think it's hospice care.
Right.
And so that's
They
why I
don't
always say
understand.
palliative care is really not hospice care. Hospice care is when we've all resigned ourselves to the fact that, okay, we're not going to beat this. Okay, so how are we going to manage this now? Palliative care is you could still have 10 years to live and be on palliative care. It's really just, I used to, honestly, at first I didn't quite get it. I used to think, isn't this how every patient should be treated, regardless of whether you're 20 or 80? It's just patient focused care, right? But our system isn't built like that. Our system is, here's a problem, fix it, right? What's the pill? And it's the patient expectation too. When I don't prescribe a medication, people think I've done something wrong. I admitted someone to the hospital today with RSV, which is pretty bad out there. So wear your masks if people are around you coughing. And she was upset that there was no pill I was giving her. And I said, well, there is no pill. You don't have a bacterial infection. What you need is some oxygen for tonight and maybe some nebulizers in case you have some wheezing. But she was really upset. She thought she wanted a specialist to come in. What was I missing? And I was trying to explain to her, well, there's not always a pill to fix this, right? So
mentality is the pill will always fix it.
Yeah, no, absolutely, right, absolutely.
Which is why when you go into CVS, the line is like so long for people waiting for multiple prescriptions.
Yes, it is challenging.
So are you're recommending hospice care in the hospital rather than?
No, I think there's a small subset of patients who A, qualify for hospice care in the hospital, and B, actually need it.
Oh,
Yeah, no, I think most people can get good care in the community, but it's not, it does require families being involved. It can't just be, oh good, mom's going home with hospice. Like that's not really a thing. Hospice is an agency that comes in and helps, but you're still going to have family there 24/7 and really be involved. So yeah, I advocate for hospice in the hospital when there's no family, so it's not possible to get that care for people at home. And when the symptoms are so severe that I can only control your pain with intravenous medications, then I advocate for keeping you in the hospital. Yeah, and Medicare is pretty good about actually. There's a benefit. It's called the general inpatient hospice benefit. Medicare actually pays a decent amount of money to allow us to do that. It's one of the few bright spots of Medicare, I would say, is the general inpatient hospice benefit. Sure. Okay. Sure. Yeah. So it's starting to happen. So the question is, how do you get palliative care outside of the hospital given the lack of providers? So it is starting to happen. Masana Care actually has a palliative care division. Hope Hospice has a palliative care division. So it is starting to happen. The reason it hasn't, and this is again a sad truth, the reason it hasn't caught on is there are billing codes that I can use in the hospital for palliative care. There are not billing codes in the outpatient setting that I can use for palliative care. So when these organizations are doing it, they're kind of doing it for free because the payment structure doesn't exist yet for that type of palliative care, which is silly and it makes no sense because if you were an insurer, you would think, if I delivered palliative care for $100, I might prevent a $10,000 hospitalization, right? So it makes no sense, but we're just not there yet societally, I think, to even think that way. But some of these more progressive organizations are attempting it to see if they can show some value proposition. The good news is, and I know, and this is a whole nother talk, so I don't even want to get into it, but Medicare Advantage plans, which some people think are the devil and some people love, Medicare Advantage is more experimental and more willing to do these things. So Medicare Advantage actually will pay for some palliative care. So if you have a Medicare Advantage plan, they might pay for outpatient palliative care because they're more likely to understand, because Medicare Advantage is like an HMO. They have a set amount of money. So they realize that sending you to the hospital is way too expensive. And so they would rather you not be in the hospital. So they're going to do everything they can to keep you out of the hospital, which might include palliative care. So depending on where you are in sort of the illness spectrum, a Medicare Advantage plan is probably going to give you access to palliative care, whereas traditional Medicare does not, which is counterintuitive. But
there's not a set way that palliative care is offered. It's got to be requested.
currently, yes, and like I said, it's really only in the hospital right now for the most part. So you're probably not going to be able to say to your primary care doc, "Hey, I'm interested in palliative care." He'd probably say, "Oh yeah, so am I. Where? Let's read about it." Right now, you'd have to be in the hospital to see. Yeah. Well, no, we'll see people in the ER too. Yeah, we have seen people in the ER and then they've gone home. So yes, so anywhere within sort of the four walls of the campus, probably you could have access to us. Last question. Sure.
Knowing that in 4 months I have a pulmonologist appointment, the lab, that 4-hour lab torture to me again, which I don't want again. And I just say to him, I'm glad to come to discuss palliative care.
You could. Who's your pulmonologist?
Keltner, Dr. Keltner.
Oh yeah. Tell Dr. Keltner you happen to run into Dr. Donovan and he mentioned something.
And I think Keltner would like to be part of your patient too.
I was going to say he might need to see me soon. Well, thank you everybody for your time.
So enlightening. Before you leave,
Pleasure.
I just want to say thank you to Dr. Donovan. I feel like we could have sat here for like another hour talking to him.
Oh,
So we'll
thank you.
probably have you back again
Okay.
another time.
My pleasure.
This is our last series for this month. We're going to take a little break and we'll probably start up again. I'll talk to Millie, but maybe April we'll do another set of 3. But in between time, January to March, I'm going to be a coordinator for this book, Living Fully and Dying Prepared, which kind of is a great segue to what we were talking about, that there's a little workbook that goes with this, and it's a 6-week class. We'll have a day and a time to be determined. I'll be the coordinator, and there'll be homework in between each class. And so you get to, we're going to go through this workbook, and it's a lot of the issues that we talked about tonight, and even more, how you want your death to look, to like what playlist do you want the music playing, when it comes to that time. And then this would be a great thing that then you would have for your family. So if you're interested in that, there is a sign-up sheet in the back, and I can only take 5 because there'll be a lot of like discussion back and forth, and we're only going to meet for like an hour and a half. So, and if you want to think about it, the workbook is available back there. I mean, this book, and that's just something that I would like to provide people, because I'm a firm believer, as is Rita, as is Levina, that bringing this out, normalizing the conversations, talking about this is what we be needing to do as a society, and maybe just as our little group, we can start to make changes, because then you people will go out and you'll talk to your friends. And so then we just become more normalized about talking about this phase of our life. So thank you for coming. I appreciate it.
Thank you.
Thank you, Ken. That was
Yeah.
wonderful.